Okay, guys, let's jump into it. Cardiovascular system. Okay, everybody, it's important to have just like a basic understanding of anatomy, as that'll help us think through the conditions once we get there. Okay, so the heart is broken into both the right heart and the left heart. Okay, so the right heart pumps blood over to your lungs, the left heart pumps blood to your body. And it's separated by that septum in the middle. Okay, um, I don't know if you guys can see my mouse, but right here. Okay, and so then blood comes in through the superior vena cava, comes down. This is your right atrium, and then it goes through the tricuspid valve into the right ventricle, and then out to the pulmonary arteries. Okay. Then this goes to the left lung, and then that goes to the right lung. Okay, and then when it comes back, it comes in to the left atrium here, down through the mitral valve into the left ventricle, and then out through the aorta. Okay, and this mitral valve is what is separating the left atrium and the left ventricle. Okay, so when you hear heart sounds, you're actually hearing the valves close. So aortic valve up here, pulmonic valve here, tricuspid, and mitral. Okay. So we were just talking about the heart. If we think about it like a house, we were just talking about the plumbing. Now we're going to talk about like the electrical wiring. Okay, so and these are listed here just as like your definitions of what you see on that EKG and what each part of the EKG actually represents. Okay, because it's important to understand, hey, so if my P waves are off or if I have multiple P waves, what does that actually mean? But I'm going to walk you through an EKG here. So this is your P wave, and like we said, that's atrial depolarization. If you remember back a couple slides ago, the atria are a lot smaller than the ventricle, which makes sense as to why their depolarization is a lot smaller than the ventricular depolarization. Okay, and just to start, a little caveat about reading EKGs. It truly is an art, okay, because nobody's is ever this straightforward and easy. And when I was a cardiac nurse, like sometimes even the cardiologists would like bicker among themselves about what was what. And so we'll go through kind of what are the crucial things that you know and that you look for, and I'll touch base about also what do I teach my nursing students for in those like dire situations, what do you have to know? Okay, so QRS, again, ventricular depolarization. ST segment is that like early ventricular repolarization, and then the T wave, and then the E wave, and then it starts all over again. Okay. Oh, and this is important to note that this ST is at this iso electric line. So it's flat. It's not elevated. It's not depressed. We'll talk about that in a little bit. Okay, so once again, just looking at now how the electrical signals flow through. So one important thing to remember about cardiac cells is that each cardiac cell has its own natural contractility, like it will cause a beat in and of itself, and that will be at different rates. But let's start with normal first. So the SA node is up here and in the right atrium, and it sends it starts the electrical impulse, which then travels down to the AV node where it gets slowed a little bit, and then it goes into the bundle branches, into that septum again, and then into your right bundle branch and into the left bundle branch, and then goes outwards that direction. Okay. And so that is when impulses are generated by the SA node, they run generally between 60 and 100 beats per minute. If for some reason this isn't working, the AV node will take over and start generating that electrical signal, and that goes at about 40 to 60 beats per minute. And then each part of your heart can generate that same electrical impulse. But if you think about it, if this is the normal pathway, if one starts, like an electrical impulse starts like over here in your left atrium or in the top of your left ventricle, it doesn't have this nice, neat pathway to follow, so it's going to look really sporadic and it's going to take a lot longer. Okay, so cardiovascular adaptation to long-term exercise. So it's a muscle, it should get bigger, right? That's true in this case, but we also have to remember that in heart failure, people's heart also gets bigger. And so there's two different types of enlargement here. So for your guys' patients, there's more muscle development, and so then with each ventricular squeeze, they're able to move more blood, and so then the heart does not have to beat as often, which is why the resting heart rate and blood pressure typically drop with more aerobic training, versus people later on in life, if they have an enlarged heart, that's typically because of like scar tissue and remodeling, which makes it so that those ventricles are actually stiffer and unable to squeeze as well. Okay, so the pre-participation examination, like the cardiac history, these are all fairly self-explanatory. Chest pain during or after exercise. Important to note, obviously, you want to know chest pain, if it's truly cardiac related, which is, can be difficult to tell, is caused because the cells in the heart aren't getting enough oxygen. And so obviously that's something that we would really want to know. And then any family member or relative died of heart problems or sudden cardiac death before the age of 50. And what I would also say is anybody die unexpectedly, because a lot of times people don't know the cause. So anybody die just like out of the blue or in their sleep before the age of 50. So these are your listening spots. As to why, as to where you need to listen. How I learned it to remember is ape to man. So the aortic valve is first, which is your A, and then you go pulmonic. We would typically listen to like Erb's point, which is kind of what they're saying is that second pulmonic valve, which is the ape, and then to man, tricuspid, and then mitral. So mitral is like that like mid-clavicular line. So in larger breasted females, sometimes you even have to get up underneath the breast. Okay, so sudden cardiac death. Really, like the prevalence in young athletes under 35 is estimated between 1 to 3 per 100,000. Not very common in young women. Obviously, it's very, very tragic, but we need to keep in mind that it's really not that common. Okay, so I'd honestly never even heard of this. So maybe I'm saying it right. Comotio cordis. I don't know. Is comes when that drastic trauma to the chest wall that interrupts the electrical impulse in the heart. I guess like everything, there's got to be a fancy word for that. We just normally call it chest trauma. And so this is what you can kind of look like. So, in that hockey player, they get hit by the puck, it interrupts the ability to create that normal electrical signal, which takes this person from their normal EKG into what looks like a coarse VFib. Okay, so this is more my area because I did advanced heart failure and advanced heart failure therapies such as mechanical hearts and transplants. So hypertrophic cardiomyopathy. This is when, like I was talking about, that enlargement of the heart muscle. So you can see on the left how how much room there is in that left ventricle for blood to fill. And then on the right, that enlargement has really cut down and narrowed that area. And so that portion of the heart isn't as able to squeeze. Hypertrophic cardiomyopathy is the leading cause of sudden cardiac death in the United States under the age of 35. Like I said, it results in a non-dilated left ventricle. And so then let's think about this. So if I just said that left ventricle is not able to squeeze and get a good ejection of blood out of it to go throughout the body, what kinds of symptoms do you think you would have if you're not able to get a lot of blood flow? In particular with the people that you guys see, like with exercise. Okay, so this is when you would see that like fatigue, shortness of breath, because their body's trying to breathe more because it thinks that it doesn't have enough oxygen, when really it has plenty of oxygen. It just doesn't have really good blood flow. Exertional angina, which is a fancy way of saying chest pain with activity, okay? And syncope or near syncope, meaning they're exercising and their body's able to do it, but their brain doesn't get enough blood flow in order to stop them from passing out. Coronary artery abnormalities. So, so when you hear of like quote unquote a heart attack in older people, it's because they get a blood clot in their coronary artery, and these are the arteries that actually feed the heart itself. Okay, so this is the second leading cause of sudden death in athletes. Most events happen during or just after strenuous exercise, and it could be because this patient doesn't have one of the major coronary arteries, or that it's abnormal. And so then I really hope you guys can see my mouse here. So then this one up here, this is an angiogram of the coronary arteries. This one is probably the LAD, yeah, LAD here, or left main that goes into the LAD, and then the circumflex. But if you look at like up here, this has really, really great blood flow. But if you look down here, these are also, you know, arteries that should be feeding this portion of the heart. So this portion of the heart doesn't have good blood flow at all. So this is an example of somebody with Marfan syndrome. Marfan's is a connective tissue disorder. Okay. It can affect the heart, eyes, blood vessels, bones. People with Marfan's are typically really tall and thin with long arms, legs, fingers, and toes, and they just kind of have this characteristic kind of linky look to them. Often we want to try to keep blood pressure as low as possible in order to help prevent that cardiac remodeling. So mitral valve prolapse and regurgitation. We had talked about that mitral valve previously, separating between the left atrium and the left ventricle. Okay, so if that valve prolapses, how blood is actually able to move is it's all about a pressure gradient. Okay, so when this mitral valve closes, the left ventricle squeezes and squeezes enough to overcome the pressure gradient, pop open the mitral valve or the aortic valve, I'm sorry, and then go out and then push the blood out through the aorta. But if the mitral valve, which is between the left atrium and the right atrium, prolapses, when that left ventricle squeezes, it's going to be squeezing some of that blood back up into the left atrium. So you're not getting a good ejection out into the aorta because some of the blood isn't going where it needs to be. Okay. So this is, you could hear like a funny murmur. Once again, you can get those symptoms of, shortness of breath, dizziness, near syncope. Myocarditis is that inflammatory, acute, or chronic process of the cardiac myocytes, so the cardiac cells, often from viruses. Okay, 5 to 22% of sudden cardiac deaths are attributed to myocarditis. So that myocardium gets inflamed, and then can actually die or cause degeneration of the myocytes around it. And then if you have myocarditis and you start physical activity, that's when issues can arise. So congenital aortic stenosis, remember looking at that aortic valve. If we talk through it again, remember that left ventricle's trying to generate a good squeeze, but if that opening to push blood out into the body is really small, you can't get as much blood out. And so some people develop aortic stenosis later on in life, some people are born with it, okay? And then like we showed earlier with the hypertrophic cardiomyopathy, the body tries to make the left ventricle bigger in order to help compensate for this, okay? But it doesn't, but bigger in this case is not better, because the way that it remodels doesn't allow it to have the flexibility to kind of fold in on itself to actually beat. And if this is the issue, death most often occurs during or immediately following exercise. And this is what that looks like. So you see on the left, that big open aorta, you can really push blood through that easily. On the right, really, really small. And then you can see that the left ventricular wall is thickened in order to try to compensate. We already talked about mitral valve prolapse earlier. This is just what we had talked about kind of in writing. So arrhythmias can occur without warning. They can, pop up and go away and vary with activity. Remember to think about electrolytes. If somebody has all of a sudden is having palpitations or has weird arrhythmias, electrolytes play a really important role in the electrical activity of your heart. So most benign arrhythmias in the athlete are due to increased vagal tone and then disappear with exercise. And why we really care about arrhythmias is because it can compromise blood flow and blood pressure. So like I said, reading EKGs previously, this is one thing that it can really help you, is you need to use the same approach every single time. And so like I said, I worked as a cardiac nurse before I got my DNP, and I was on the code team, and so it was important to, if I was walking into, a code blue, or if I was just coming on shift and checking out my patient's rhythms, I need to follow the same steps each time to make sure that I'm not skipping anything or missing anything. So that way, when you are in those like more high intensity situations, you can trust your process, okay? So the first thing you want to look at is it regular or irregular? And most of the time you can just eyeball that. Does it look like the QRS beats are happening at about the same time or not? Is it too fast or is it too slow? So is it over 100 beats per minute or is it under 60 beats per minute? Is there one P wave for every QRS? Does that QRS look normal, meaning is it not too wide? And then is that ST segment normal or not? Okay, so is it elevated or depressed? And that's that sign of cardiac ischemia. So a couple of things that are considered normal. Okay, so oftentimes people say they come to me and they say, oh, I have an irregular heartbeat. okay? But that doesn't necessarily mean that anything's wrong. So there's lots of different things that could be causing that irregularity. So PVCs for one, which is premature ventricular contractions, and I'll go through these again in a minute. And then PACs, which are premature atrial contractions, and then sinus arrhythmia. Sinus arrhythmia is super common. It's essentially that your heart rate speeds up and slows down with inspiration and expiration, and there's absolutely nothing wrong with it. Okay, so like I said, I hope you can see my mouse. So this up here in the upper left, okay, this big like wonky looking thing, and then there's two different ones here, are PVCs. And sometimes these can be what people feel when they say they have palpitations. People get these a lot more commonly if they drink a lot of caffeine, okay? And so these people are having PVCs like every third beat or every other beat. And the problem with that is that these could be non-pulsatile, meaning that they don't actually create enough of a squeeze to cause blood flow to move forward. So then you can essentially take this person's heart rate and divide it in half, okay? And so this could be, and pretty much everybody has these, not this common, but just every once in a while, okay? And then over on the right, this is how you can, this is a indication of a PAC, and I'm not showing you these in order to like, you know, make you try to remember them, but just to know that if you look at that, that looks irregular, but it doesn't, it's not necessarily bad. And then the one on the bottom, that's an example of your sinus arrhythmia. So it speeds up and slows down based off of the pressure changes with respiration. Wolff-Parkinson-White syndrome. I had to actually ask James why this was highlighted in there. Out of all of the different arrhythmias, why is this one that they wanted us to go through? Because honestly, I've never even seen it in practice. In my 6 years in the hospital and a couple of years in the outpatient world, I've never seen it because it is pretty rare. It occurs in 0.1 to 3% of the population. And the fancy way of saying it is that ventricular pre-excitation and tachycardia resulting from electrical conduction over accessory pathways. That really cleared things up for you guys then, huh? So if you think back to that picture of the SA node, the AV node, the electrical activity traveling down the bundle branches and then out into the ventricles, it's essentially saying that that first electrical impulse is coming from multiple different spots, okay? So typically how we think of it is you see multiple different shapes of P waves because it's coming from multiple different locations in the heart, okay? And even the incidence of Wolff-Parkinson-White in athletes is pretty low. This could be an example of that, because they say that it's defined as that like delta wave right before your QRS, but this could also look like a junctional or all sorts of other things. So, and obviously I'm not going to get into that. So long QT syndrome. So ventricular repolarization abnormality, meaning that QT time is too long, affects 1 in 2,000 people and has a low rate of death in athletes. And there is a genetic risk, and there's a high risk for syncope and ventricular arrhythmias. When I think of long QT, I think of medications, okay? So like Zofran, your anti-nausea medicine, can really prolong that QT. And the issue is, okay, so the top one is how long it should take for that ventricle to repolarize. So on the bottom one, that ventricle is trying to repolarize, but it's taking a long time. But here, like once we get to like here, part of the ventricles are already ready to fire again. And so if you were to get a QRS right here, okay, half of that ventricle is ready to fire. And so you can actually send yourself into like a torsades or a BTAC or something like that, because it's called R on T phenomenon, meaning that this next beat hit right on the right spot. So it was able to depolarize half of the ventricle and then send you into bad rhythms. Okay, so let's talk about blood pressure. How much blood pressure is exerted on like the walls of the blood or the walls of the vessels and the blood itself. So it has a peak and trough, that's at systolic and diastolic. The difference between the two is the pulse pressure. Average is 120/80. And then I always like to bring it back to you guys, like, why do we really care? So blood pressure is about how much oxygen are the cells receiving, okay? And if your blood pressure is too low, the cells, predominantly in your kidneys and in your brain, won't get enough oxygen and then will start to die. If your blood pressure is too high, it's exerting too much pressure on that vessel itself, and it can cause that vessel to break. And that's when people have strokes. So if we think about hypertension, we just spent a long time talking about sudden cardiac death, but let's bring it back into, like, perspective. Sudden cardiac death is really rare. If you want to save or like actually do some benefit for your athletes, find their hypertension, okay? So it's the most common cardiovascular disorder among athletes and people. It's quote unquote the silent killer because hypertension typically has no symptoms, okay? And elevated blood pressure for years can result in all of these different things on the right: heart disease, coronary artery disease, atherosclerosis, renal disease, visual changes, neurologic impairment, because there's damage being done to all of those different blood vessels throughout pretty much your entire body, okay? And elevated blood pressure results from increases in that total peripheral resistance. And so you have smooth muscles surrounding your arteries, and sometimes they tighten too much, and that is like an external way to increase your blood pressure because that lumen is smaller. But then it's important when you guys are taking blood pressures to think about other causes of high blood pressure, like exercise. Your blood pressure is supposed to go up when you start activity. And so to get a good blood pressure, your patient really has to be seated for 5 minutes, okay? And then anxiety and pain are also a huge cause of increases in blood pressure. So keep that in mind as well. In order to actually diagnose hypertension, you have to have 2 episodes of elevated blood pressure on 2 separate occasions. These are the AHA's guidelines for normal and the different stages of blood pressure. Okay, so deep vein thrombosis. First, let's talk about what's the difference between an embolus and a thrombus, okay? So we're going to talk about pulmonary emboli and deep vein thrombosis. So a thrombus is a clot. An embolus is a clot that has moved. It's that simple, okay? So deep vein thrombosis is when there's a venous blockage with stasis, so blood just kind of hanging out distal to the clot, which makes sense, right? If there's a blood clot, blood can't move past it, okay? So it happens most commonly in the lower legs. Subclavian vein thrombosis can happen in baseball pitchers, but think about risks for this. So your athletes that are traveling to different areas, okay, they spend a lot of time on a bus or in a plane. Okay, so those are big risk factors because it just lets that blood pool in their legs. So make sure they're getting up and walking around, or at least pumping their legs around. This is what that looks like. Okay, and then I also like this picture that it shows how the leg itself will kind of swell up. And then pulmonary embolus. is that possible complication of the DVT. So if you don't find the DVT, it's possible that it can then travel to the lungs. And if that vessel is where it lodges is large enough, gas exchange is interrupted, and if that happens for a long enough period of time, patients can actually die. Okay, so important to think about injury and trauma that can also elicit a hypercoagulability response in otherwise healthy athletes. But also, here's the big one to think about, guys, COCs, which is combined oral contraceptives, okay? So if any of your female athletes are on the birth control pill, so not other kinds of contraception like IUDs, implants, anything like that, but the birth control pills have a higher level of estrogen, okay? And the estrogen increases their risk for clotting. And so that is a huge thing to keep in mind if you suspect a DVT or a PE. And then this is just what that looks like as well. Peripheral arterial disease. So that atherosclerosis, which is that, narrowing of the vessels, that occurs everywhere, not just in your heart, okay? So peripheral arterial disease is pretty much atherosclerosis everywhere else. Your book mentions that it's the same as peripheral vascular disease, which isn't technically true. Peripheral vascular disease is an umbrella term for a whole bunch of different diseases. Peripheral arterial disease is a certain one, usually presents after age 50. In smokers, people with hypertension, diabetes, high cholesterol. You get symptoms of cramping, weakness, pain or numbness in the affected muscle, and that intermittent claudication, meaning you get pain with activity that resolves with rest. And what that is not enough blood flow to that muscle. So that pain is actually cellular ischemia. Anemia can be a whole bunch of different causes, such as iron deficiency, exertional hemolysis, or just dilution. More common in endurance athletes and also females. The hemolysis can happen. So hemolysis is, breakdown of red blood cells. And that can just happen because of, how intense their physical activity is. And so if you have someone that's like, I'm just so tired all the time. I can't, no matter what I do, I'm tired, I'm breathing heavy, I just am not feeling right, look for anemia. Sickle cell trait or anemia, it's a genetic defect. Trait is if you have one copy of the abnormal gene. Full expression is with 2 copies. And essentially, this it just causes your red blood cells to, look differently, which can result in this quote-unquote log jam. And so this is what it looks like. So because they're not round, part of why your blood cells are round, because they can be squished and moved around well. This sickled red blood cell, it makes it a lot easier to cause blockages in your vessels.